I'm Dr. Corey Cutler. I am the director of the stem cell transplantation program at the Dana-Farber Cancer Institute and a professor of medicine at Harvard Medical School. Today, we're going to discuss treatment options for the management of chronic graft-versus-host disease with fibrotic features. We all know that chronic graft-versus-host disease, if left untreated or treated incompletely, will eventually lead to sclerotic or fibrotic manifestations in a number of organs. We tend to think about the skin with fasciitis and scleroderma as the main manifestations of fibrosis, but it's important to understand that microscopically there's fibrosis of the lacrimal glands, there's fibrosis of the salivary glands, and so fibrosis is really the end game of all of the inflammatory phenomena that we see associated with chronic graft-versus-host disease. It's very clear that in modern times, with better acute and chronic GvHD prevention using agents such as post-transplantation cyclophosphamide or antithymocyte globulin, that the incidence of both chronic graft-versus-host disease and sclerotic chronic graft-versus-host disease is falling. That being said, there are still a significant number of patients who are affected and who require our attention. Currently, there are 4 approved agents for the management of chronic graft-versus-host disease. In order of approval, those are ibrutinib, belumosudil, ruxolitinib, and axatalimab, and that's the order of approval in the United States. Now, before we talk about specific management of fibrosis, it does need to be mentioned that none of these agents have specifically been proven to be better than one or the other for the management of fibrosis. However, there are some factors about the individual agents that appears to make a couple of them better choices for the management of fibrotic disease. We know that ibrutinib and ruxolitinib can treat fibrosis. Their mechanisms of action, which include impairment of the B cell system and perhaps the T cell system for ibrutinib, and a reduction of inflammatory cytokine signaling for ruxolitinib, do not necessarily make them obvious agents for the management of fibrosis. However, I think all of us as clinicians have seen fibrotic responses to these 2 agents. The 2 agents that might deserve a little more attention in this setting are belumosudil and axatalimab. Belumosudil, which is a ROCK2 inhibitor, not only decreases inflammation at the level of the germinal center, but the ROCK2 enzyme or kinase is particularly important for some of the upstream signaling that leads to fibrosis. That is transformation of fibroblasts into myofibroblasts that lay down collagen, and even some of the collagen regulatory pathways are regulated in part by ROCK2. And so for this reason, belumosudil has intrinsic antifibrotic activity. Axatalimab, which is a monoclonal antibody directed against the CSF1 receptor, is also an agent with apparent and important antifibrotic activity. The CSF1 receptor is found on the cell surface of the monocyte macrophage lineage, and this is the cell line that is important in laying down collagen as well, but also in removing collagen from tissues. And so both of these agents appear to have independent antisclerotic activity. There are clinical trials looking specifically at these 2 agents, specifically for the management of the fibrotic manifestations of chronic graft-versus-host disease. We don't have the results of these trials yet, and there have been no head-to-head comparisons looking at outcomes of individual agents compared to the other. The other thing we need to think about in the management of fibrotic chronic graft-versus-host disease is thinking about introduction of the newest antifibrotic agents that are not necessarily anti-inflammatory, so outside of the immunology space. And there are several of these that are coming down the pike. We have to look to our colleagues in the nephrology and hepatology space, and even in the lung space, idiopathic pulmonary fibrosis, where there are agents that are being specifically developed for the management of sclerotic disease there. And I think in the future, we're going to find ways to integrate these novel agents into the management of sclerotic chronic graft versus host disease. Thanks very much for your attention.